Hi, this is Brian Kim. I'm going to share with you case number 225 in the best way to do cataract surgery series. Again, this series is titled this way, not to say this is the best way, but to encourage you to think about what is the best way that I can do the surgery and constantly adjust your technique, modify your technique, and hone and refine your technique so that you can provide best surgery for your patient. So this is a routine lens disassembly, a rather soft lens. You're going to see double chop, cross chop mechanical fracturing techniques to efficiently disassemble the lens with low CDE. And you're going to see this toric lens pop out upside down. You can see how I navigate through that and how I'm able to position the lens at the end of the surgery. So one thing you notice here is I noticed that the typical Lieberman speculum was not providing adequate exposure. And so I'm switching to this narrow blade speculum. And so take a look. You can see so much more exposure with this small blade. And I believe it's because with the bigger blade, because as you widen and stretch, it causes a rectangular configuration, but with the small blade, it almost causes like a diamond configuration, so you get more superior and inferior exposure. So I use a corneal marker to help me in center incise rhexis. And these are my paracentesis incisions, first on the right side and then the left side, making sure the blade is parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. And I'm going to use a two-handed technique. You can see I'm using the Orlock technique. This patient has a Bell's phenomenon. This is the left eye. I'm turning the cannula and then I'm able to pull the eye down with the technique. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then when I'm ready to enter, you saw I was able to wiggle and then it goes in nicely. And these are the micro forceps that I use from Moria. I puncture the center. And the key is, you see I have a two-handed technique. I'm able to control the eye. This patient has a strong Bell's reflex. I'm using the Orlock technique to turn the cannula sideways, so I'm able to pull the eye down. If I have radialization forces, I can push more viscoelastic to flatten the anterior capsule. So this is my two-handed technique in doing capsulorhexis. I'm going to puncture the center, and it does have a sharp tip on these forceps. You see the low profile of the forcep as well. I'm going to pull down towards me and then nudge a little bit to the right, which creates a flap. Start to go around circumferentially using the corneal mark that I made as a guide to achieve a well-centered incised rhexis. Again, using that cannula to control the eye since this patient's trying to turn upward with the Bell's reflex. Finish off the rhexis. Burp some viscoelastic out. And this is the Capsulorhexis hydrodissection technique. I place the cannula under the rhexis edge contra-incisionally. I get into the capsulorhexis. I turn the tip down and do a little bit of a wiggle maneuver. And then as you push the plunger, you're going to get a really nice, easy flowing hydrodissection wave. It shouldn't require any significant effort. You shouldn't have any resistance. And this is a much more efficient way and a targeted way to aim that BSS into that space that you want to go posteriorly, not anteriorly. So again, getting under the rhexis edge, point it down, you get a nice wave. I lift the lens up, which decompresses the bag as well, and now you see the lens begins to spin. Irrigating the surface of the eye, and then lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material. And again, this is a fairly soft lens. You're going to see I'm going to place the chopper under the rhexis edge contra-incisionally, and then I'm going to turn it vertically. And remember, the elbow of that chopper is going to be parallel to the anterior lens surface, which means the tip of the chopper is down at the level of the lens material, the thickest part of the lens material, right? The chopper is about 2 millimeters long. The lens is 4 millimeters. And so you have plenty of cushion. You're not going to rip the bag or anything like that. Again, you have double the distance. So again, I'm positioning it down, but look here, I'm turning the phaco tip vertically subincisionally. And because the lens material is soft, look, it's just cutting through. Again, I'm not using any ultrasonic energy. That's very important for you to understand that. This is purely with infusion pressure. Infusion only, no vacuum, no ultrasonic energy. You can see the settings right there. I'm going to just tilt the phaco tip vertically, and I'm stabbing into the lens material. It's like stabbing into jello. It's going to cut very easily through the jello without causing any damage. It's not going to move and cause any translational movement. I bring both instruments together because I'm flanking the lens, and it crushes the lens completely in half. I place a chopper around the right heminucleus, hooking the peripheral lens, crushing it against the phaco tip, and that is a cross chop maneuver. And grabbing that first quadrant up, crushing the lens into smaller and smaller pieces, and then emulsifying the lens piece. Very efficient way and targeted way using mechanical fracturing forces to disassemble the lens. Using the chopper to pop that second quadrant up very carefully, crushing the lens pieces into smaller pieces, and then emulsifying it. Turning the second heminucleus in front of me, placing the chopper around the lens, hooking the peripheral lens, pulling it centrally toward the phaco tip, and crushing the lens against the phaco tip. Again, the phaco tip is acting like a chopping block. Lifting that third quadrant up with some vacuum, and then crushing it between the instruments, crushing it again between the instruments, again using only mechanical forces, and then once the pieces are small enough, emulsifying the lens with ultrasonic energy and vacuum. Again, pulses of ultrasonic energy and vacuum. Turning that last quadrant in front of me, placing the chopper around the lens, pulling it centrally toward the phaco tip, and crushing the lens again in a cross chop fashion. And then once those pieces are mobile, just crushing the lens between the instruments. Removing the epinucleus now. Again, very efficient, easy way to disassemble the lens. So I take the chopper out, push BSS in, take the phaco tip out, and then I go in with the ironing handpiece. You can see there's quite a bit of cortex still left. I'm going to start subincisionally with this polymer tip, and I prefer coaxial because of that polymer tip. The polymer tip is very, very safe, and thankfully because of that, I've been able to avoid any really major troubles with INA and risk of posterior capsule rupture. It's so safe that I oftentimes will use the polish mode and polish the posterior capsule, polish under the rhexis edge. I have tremendous confidence with using this polymer tip in this setting. Cleaning the bag and removing the lens epithelial cells, in my opinion, is very important. I mean, just in general, it makes sense. Why would you want to leave that lens material? I think it's a higher risk for PCO formation and capsule contraction. I'm pulsing into the subincisional capsule fornix with that BSS cannula, which was clean, and then filling the bag with cohesive viscoelastic, disengaging the irrigation first, because if I don't disengage the irrigation, the viscoelastic will just come straight out. And then this is a sweep. Again, I'm doing a belt and suspenders approach to cleaning the bag. I use the INA polish mode first, and now I'm using the sweep to sweep under the rhexis edge, first on the left side and then the right side. And as you can see, there's marks on the eye, which means this is a toric lens for the patient. So the lens is going in, and so far it looks pretty good. Hard to tell the orientation of the lens until it starts to open up. And as it opens up, I go ahead and put the INA handpiece in, and then I start to realize that the lens is upside down. And how do I know this? Because the lens should be a backwards S. And in this case, you can see the lens is actually in the S configuration. S is sorry for, that's not the correct orientation for the lens. It needs to be a backwards S or a number 2 configuration, or the leading haptic should be a 7 configuration. It doesn't really matter. The point is it's upside down. So with infusion on, I decide to tilt the lens and rotate it. Again, this is a patient who is a high myope, big bag, big eye. And so I felt like I could just flip it over. And so that's what I did, keeping infusion on. I just got under the lens and I just rotated it and tilted it and flipped it over. And so here I'm getting underneath the lens again, just to make sure that both haptics are properly oriented. Yeah, you can see that leading haptic was still a little bit caught on the capsule. So now it's sitting nice and flat, and the lens in the proper orientation. I'm getting under the lens again, removing the viscoelastic from within the bag, And so this is another trick. Those people who are scared to go underneath the lens to remove viscoelastic, they would be very uncomfortable with what I did, right? Because they're not used to that and they're scared of it. Well, because I know how to do that on a regular basis, I was able to flip this upside down toric without any trouble. And it goes to what I'm saying, and I've always said, you have to stretch yourself and try other techniques, things that might seem uncomfortable, but if you master it and get good at it, you'll realize it's not very scary. More importantly, you'll find yourself in situations where you can leverage those techniques to your advantage when things happen. So obviously, the technician didn't do that on purpose, but the lens came out upside down. And so, what are you going to do? Take it out? You're going to cut it out? You're going to do something else? That might cause more risk when you do all that. But because I knew this is a big eye, I was able to turn infusion on, get underneath the lens because I know how to get underneath the lens because I do it all the time. And I was able to gently flip it over, making sure that as I'm flipping it, the lens was not going to touch the cornea, and then making sure both haptics were oriented properly, and then position that lens in the proper axis for the toric lens. So again, you saw efficient, routine lens disassembly. This lens was probably like a 1 to 2 plus stents lens, but very efficient double chop, cross chop, leveraging mechanical fracturing forces, not going after the lens pieces and pulling them out of the bag with high vacuum or ultrasonic energy. To me, that's just risky and unnecessary. And so I was able to leverage, as I always do, mechanical fracturing forces, hooking the lens piece with the chopper, pulling them pieces out of the bag, and I was able to orient this toric lens in the proper orientation at the end of the case. So I hope this was helpful to you, and I thank you for your attention.